what do you see sort of as a blue sky thing? What do you think will change in the next 20, 30, 40 years?
Oh gosh. I think you've actually indicated in what you said already that the problems we faced 40 years ago, 30 years ago, are still here. They're modified and much better, and the results have considerably improved, but they're still the same challenges that we faced back in those. How do you manage graft versus host disease? What is the cause of aplastemia? What is the target, if there is indeed a autoimmune function that go? I'm particularly interested in the microenvironment and the bone marrow, the niche, which I know my dear colleague Professor Marsh, when she was at Manchester, showed in some experiments that it's probably the stem cell that's at the target, but I'm not totally convinced. I think the target might be in the niche.
Okay.
So that's
loads of work to do then.
Loads of work to do, yeah. And the other thing that really fascinated me is some people get better. And also after bone marrow transplantation, marrow regenerates. In some cases, it's their patient's own marrow. But I want to hear about your stuff, because it's a long time since I practiced.
Yeah, we are trying. So I think a couple of things is that so historically you touched upon how transplant evolved or started in aplastic anemia in the 70s, and as you very much said, there has been trials of doing half-matched haploidentical transplant even in the 80s and 90s, but unfortunately had significant complications. But I think in the last 10, 12 years, through the Johns Hopkins Baltimore approach of using post-transplant cyclophosphamide on day 3 and day 4, being able to overcome that barrier of half-matched transplant. So people without any identical sibling donors or unrelated donors, we've been able to offer haploidentical transplant, and it's quite critically important for ethnic minority, non-Caucasians who do not have matched donors in the registry, and with the shrinking population family sizes as well. So that is now being taken as very much a standard of care that we can offer transplant. So at least if somebody is generally fit without significant medical problems, transplantation should be always thought about in anybody who walks in with aplastic anemia, either as a second line or a third line in the context of haploidentical transplant. So that has definitely changed our spectrum of thinking in the treatment management. The second thing you talked about is we've always been stuck with the 60 to 70% response rate with horse ATG with cyclosporin and steroids, mainly for serum sickness prevention. So L-Trombopag, again, I always like this context of serendipity in medicine, is it? Because I know you've done so much studies about looking at TPO levels in aplastic anemia. It's extremely high. Thrombopoietin as a hormone which stimulates production of platelets, and nobody felt that L-Trombopag will have an effect. So they did NIH did a very small study of using L-Trombopag in refractory relapsed who had high levels of this hormone. But they found surprisingly 40% of patients had a response. Similar to the context of you saying, do we need to use some drugs to stimulate the bone marrow as well as suppressing the immune system? We've added in ATG cyclosporin with L-Trombopag, and nearly 80-90% of patients have a response. And also they get a rapid response, i.e. they get a response within 3 months. And the proportion of patients who get a complete response has also gone up from 10% to 30-40% as well.
Brilliant.
And they're able to come off the L-Trombopag. So that's one. And as you know, we are trying to do more trials through AAT and other funding of using autologous T regulatory cells, expanded autologous T regulatory cells from patients, expanding them outside and then reinfusing them back to patients. This is a very early phase trial, but this is fascinating. And we are very much interested in studying the clonality, i.e. the mutations in patients with aplastic anemia. Why would a disease which is a purely autoimmune disease have genetic defects in the bone marrow stem cells? and that's quite fascinating as well. And we are trying to see whether we can look at it to see whether it will be able to identify patients who potentially can go on to develop acute myeloid leukemia and MDS, which, as you said, we don't want them to get. It's less 10%, 15%, but we don't want patients to go on to develop leukemias and myelodysplastic syndrome.